Hello, my name is Jeff Messerol, and you met me on Thursday. I am going to be the instructor who does the vast majority of all the lectures, and I'd like to welcome you to the first of many talks in the paramedic program. And I think a good as place as any to start is with the roles and the responsibilities of the paramedic. So we'll go ahead and start with this particular talk, and at the end there'll be a directions on how you can ask questions and reach me as well. The objectives that we hope to cover in tonight's talk include defining what an EMS system is, defining the differences between licensure and certification. In Iowa, they actually mean the same thing, but in some states they are different. We'll talk about a profession, define professionalism, define who a healthcare professional is, as well as ethics concerning EMS. We'll look at the definition of medical direction, protocol development. We'll also look at the key historical events that have influenced and shaped the development of what we now know as a national EMS system. We'll discuss the roles of National Registry and how national groups, other national groups, are important to the development, education, and implementation of EMS. We'll identify standards or different components of an EMS system that have been defined by the National Highway Traffic Safety Administration, or NHTSA. We'll distinguish between local and nationally recognized levels of EMS training and education that lead to licensure, certification, and registration. We'll explain paramedic licensure and certification. We'll talk about recertification. We'll talk about reciprocity requirements. And we'll evaluate the importance of maintaining your licensure and certification. We're also going to describe the benefits of continuing education for paramedics as lifelong learners. It doesn't end here. We'll describe how professionalism applies to paramedics when you're on duty as well as when you're off duty. Describe the attribute of paramedics as a healthcare professional. And we're going to list some examples of professional behavior displayed by the paramedic to include things like integrity, empathy, self-motivation, appearance and personal hygiene, self-confidence, the ability to communicate, the ability to manage time, work together as a team, and the development of mutual respect. We'll also talk about some other examples of professional behavior to include advocacy and the careful delivery of medicine. We'll list some primary and additional responsibilities that paramedics have, as well as discuss the benefits of community involvement. We'll analyze how paramedic benefits healthcare systems by providing primary care to patients in a pre-hospital setting, by being an extension of the hospital and bringing that emergency department to the patient. We'll discuss citizen involvement in EMS systems, as well as describe the role of EMS physicians, and discuss the benefits of both online and offline medical direction. We'll describe the process for the development of local policies and protocols, as well as describe components of continuous quality improvement, the role of continuing medical education and research. We'll explain some basic principles of research, what your role in data collection is, as well as data contribution, and we'll describe the importance of quality EMS research on the future of EMS. Now, EMS offers us opportunities and challenges that you just don't find in many other jobs. No 2 days are going to be identical. And we see patients in the worst of times, in the worst of conditions. And so it's essential that we understand what our role and responsibility of a paramedic is in those situations. A professional is defined as a person who has special knowledge and skills. And as a paramedic, you certainly have special knowledge concerning emergency medicine and a special set of skills that go along with that knowledge. As a paramedic, you must conform to the highest standards in EMS care and we'll talk about what those are. EMS systems are not standalone systems. EMS systems are an extension of healthcare, often the first point of contact for patients in the healthcare system. And as a system, we work with an additional network of resources to include hospital emergency departments, intensive care units, rehab units, long-term care facilities, public health, and a variety of others. It is the responsibility of the EMS system to provide emergency care, transportation of the sick and injured. And it's a very young system, beginning with its roots in the United States in the early 70s and still developing as we look at evidence-based medicine, as we begin to develop protocols based on evidence. An EMS system is an integral part of the medical community, as we'll discuss. It's often viewed as the third leg of public safety, where law is one leg and fire is one and EMS is the third. Now, EMS systems are part of a larger system, part or an extension of medicine, which includes the emergency medical services or the pre-hospital system, the emergency departments within a hospital, the surgical treatment areas, the intensive care units, the rehab areas, and then upon discharge, perhaps long-term care facilities or assisted living. And as I had mentioned, EMS systems are often the first line of access for patients when it comes to obtaining medical care. EMS systems are continually being updated and modified based on available evidence. And as the EMT and paramedic, you're the core of the EMS system. You are healthcare professionals. As a healthcare professional, you provide thorough assessments, aggressive treatments. You bring the emergency department to the patient, as I had mentioned, and then provide safe and timely transport to an appropriate destination, getting that critically injured trauma patient to a level 1 or level 2 trauma care facility, getting that STEMI patient to a cath lab, getting that stroke patient to a stroke-capable hospital. Now, as we look at the history of EMS, some would say that Baron Dominique Jean Leray, in 1797, the battlefield surgeon for Napoleon, developed the first ambulance systems, or EMS systems, and they included wooden carts that were horse-drawn, where they could load 1 or 2 injured patients into the back, and they would fly like the night to a field hospital where they would receive care. Now, of course, no care was provided to the patient in the back of this ambulance. They were just placed there, and the driver often rode the horse that pulled the wagon. Some of the first horse-drawn ambulances in the United States showed up in 1865 in New York and Cincinnati. And in World War I and II, we had combat medics, field corpsmen, who provided initial care while getting the patients back to battlefield hospitals. In the 50s and 60s is when we first were introduced to mouth and closed chest compressions for patients who were presumed dead. And it was in the Korean and Vietnam Wars that MASH units, or mobile army surgical hospitals, began to develop. But EMS took a major turn in the United States when the National Academy of Sciences National Research Council published a paper known to become as the White Paper. It was titled "The Accidental Death and Disability, the Neglected Disease of Modern Society." And it reported the inadequacies of emergency care in the U.S., particularly as it related to trauma care for those people who were dying on our highways. It made 29 recommendations for improving care to injured victims, which included the development of emergency medical services, the development of ambulances, and the development of training for providers who would care for these injured victims. As a result of that paper, Congress passed the Highway Safety Act of 1966, which created the U.S. Department of Transportation and also created the National Highway Traffic Safety Administration. And these two organizations still thrive today, with the DOT being tasked in the 1960s to develop curriculums and train what later were to be called emergency medical technicians. And NHTSA also went on to help the DOT, as an arm of the Department of Transportation, to look at highway safety and to look at motor vehicle safety and to look at standards and those sort of things, and help develop EMS as well. In 1973, the EMS Systems Act provided federal guidelines and federal dollars for the development of regional EMS systems across the United States. But in order to receive the dollars, it required that EMS systems meet 15 separate components in order to receive that funding. In 1991, the Omnibus Budget Reconciliation Act consolidated all the federal funding into a state preventative health block grant. And that's how much of EMS is still funded today from the feds, is through these health block grants that come down to the state, and then the state disseminates that out to different EMS systems. In 1984, we saw the development of emergency medical services for children as a result of EMS systems not being adequately trained in the care of ill and injured children, as well as having proper equipment. In 1988, NHTSA developed the Technical Assistance Program, which incorporated 10 essential elements, and they're listed there, 1 through 10, that were required of EMS systems. I guess nothing was ever really required as much as it was guidance and direction, that if you addressed each one of these essential elements and met the guidelines, then certainly you were eligible for funds. In 1990, the Trauma Care Systems and Development Act was signed, which allowed states to receive federal funds to develop their trauma systems. Iowa took advantage of that in 1991, and by 2001 had completely redesigned and developed their trauma systems program. We're writing code into law, developing things like the out-of-hospital trauma triage decision protocol. And in 1991, the National EMS Education and Practice Blueprint identified 4 levels of EMS professionals. And of course, by 1991, there were multiple levels of EMS professionals with names of their own. But the National Practice Blueprint identified just these 4, and states moved to incorporate this verbiage, that we would have first responders, and then we would have EMT basics, and we would have EMT intermediates, and we had to have EMT paramedics. And the National EMS Education and Practice Blueprint went on to develop curriculums developed by the Department of Transportation with input from NHTSA to train these 4 levels of providers. In 1996, NHTSA created the EMS Agenda for the Future, and also developed the EMS Education Agenda for the Future, a systems approach. And both of these are excellent and relevant documents still used today in shaping and developing EMS systems. They both can be found at the website www.ems.gov. The federal government is also taking an avid step in advocacy based on lobbying from organizations like the National Association of EMTs and the American Ambulance Association, and the Federal Interagency Committee on EMS, or FICEMS, is now the federal watchdog and the federal agency that looks at developing evidence-based practice guidelines, as well as in 2014 they published the Strategic Plan for EMS System Development, which identified 6 goals and 30 objectives that they would like EMS systems to achieve over the next 5 years. And as I had mentioned, EMS is not, by itself. There are relationships with national organizations as well as state and local organizations. A couple of the national organizations that we're going to mention include the Committee on Accreditation of Educational Programs for EMS Professions, or COAEMSP. Now, COAEMSP is the organization that has developed criteria and inspects training programs, and if they pass muster, then they're allowed to provide education at the paramedic level, and those people who graduate from a COAEMSP program are allowed to sit for the National Registry written and practical exam. As you well know, Iowa Western Community College is one of the few handfuls of community colleges in Iowa that has achieved that COAEMSP accreditation. The National Registry of Emergency Medical Technicians measures the readiness of program graduates by testing them, by having them successfully pass a written exam and a hands-on skills practical exam. And when those 2 exams are practiced, the National Registry can say with great certainty that those who have passed those exams are level entry, ready to provide the set of skills that they have been taught in their program. The National Association of EMTs was founded in 1975. It is now the largest EMS association in the United States, focusing on 3 primary areas. NAMT is very big on advocacy for EMS providers in all walks of medicine. They have a very strong lobbying and legislative arm of the association, as well as education committees that have developed programs like PHTLS and AMLS that you will take as part of your training here at the Paramedic program. We have state organizations as well, and of course the organization that oversees, regulates the EMS system development and the certification and recertification of providers is the Iowa Department of Public Health's Bureau of EMS. And it now resides within CDOR, which is the state organization that addresses disaster response. And within the Bureau of EMS, they have different boards, councils, and committees that guide and direct them in their legislative efforts, as well as their rules and regulation publication, as well as their protocols and scope of practice. The EMSAC, the Emergency Medical Services Advisory Council, is made up of multiple physicians from all the different organizations, as well as the Iowa Firefighters Association, the Iowa Hospital Association, volunteer and paid providers, educators. And I do sit on that board. In fact, I'm the co-chair of EMSAC. And we advise the Bureau of EMS on matters concerning protocol development, scope of practice, and other issues that we are asked to look at. There's a subcommittee of EMSAC called QASP, the Quality Assurance Standard Protocol Committee, that writes the scope of practice as well as writes the protocols for the state of Iowa and makes those recommendations for endorsement by EMSAC. TSAC is the Trauma Systems Advisory Council, and CQIC is the Systems Evaluation Quality Improvement Committee. And CQIC is now part of TSAC, and they regulate Iowa's trauma system. And then, of course, you've got your local county EMS associations, your local Board of Health, your local county Board of Supervisors, as well as your local service director and medical director. The National Standard Curriculum is what is now used, and it outlines information at each level of EMS education. It looks at the didactic, the laboratory, the clinical, and field internship requirements to be trained at one of the 4 particular levels of EMS. Also developed by the National Standard Curriculum Group is the National Scope of Practice. And the National Scope of Practice was adopted by Iowa in 2012 so that we could move forward with most all states in the United States adopting the same scope of practice for their 4 levels of EMS provider. The National Standard Curriculum addresses these components that we saw earlier from the TAP group and also includes instructional guidelines that identify the type of material that needs to be covered and the objectives that need to be met when training an emergency medical responder or an EMT or an advanced EMT or, in your case, a paramedic. The current levels of EMS professionals that we are moving to, we're not quite transitioned yet, but will be in the next couple years. The emergency medical responder used to be the first responder. The emergency medical technician used to be the EMTB, the EMTA, the EMTD, the EMT. The advanced EMT certainly is a new level, but the EMT intermediate and the EMT, the I-99 and the I-95 and the I-99, those 2 different curriculums could, with some additional training for the I-95s, become advanced EMTs. And then, of course, we have the paramedic, which used to be called the paramedic specialist in Iowa. Now, in addition to these current certifications and licensure, we do have specialized endorsements, which in no way is a certification or a licensure, but just an endorsement that this particular EMS provider has completed some additional education. Some of the endorsements that are out there include EMSI, which is the EMS instructor, which when you complete that course, you're allowed to coordinate EMT classes and paramedic classes and advanced EMT classes. The EMS evaluator allows you to be an evaluator at a National Registry Practical. The CCP is the critical care paramedic, again, which is not a licensure or certification. It's just an endorsement that indicates that you've had some additional training as a paramedic to broaden your skill set for those patients that you have to do inter-facility transports with. And then the flight paramedics all are required to have additional training and certification to broaden their scope to address those skill sets needed as a flight medic. Now, we've talked some about licensure certification, and in the National EMS Scope of Practice model, certification is defined as an individual who has demonstrated competence in skills or roles. And certainly by completing the National Registry Written and Practical Exam, we have demonstrated competency in a particular skill set. And so we are certified as paramedics. Licensure is the state-issued legal authority to perform those skills. And in the Iowa Code, it does identify certification occurs when we complete the National Registry Written and Practical Exam and upon licensure by the state. In other words, they issue us a state card. We are licensed to perform our skill sets, but in Iowa it is only allowed to perform our skill sets if we are aligned with a service and we have a medical director who has credentialed us to perform our skills using their medical license. Now, reciprocity is one of the reasons that we've gone to the 4 levels of EMS provider in the National Scope of Practice model is so that as Iowans travel to other states, that they can continue to provide the care that they provided in Iowa, because most all other states have adopted the 4 levels of EMS certification as well as the National Scope of Practice. Registration, this occurs when you registered for the class on Thursday night, and it occurs when you register with the National Registry to take your written and practical exams, and it occurs on a state level when you registered, or you are registered as part of an authorized service program. I'd mentioned that we are lifelong learners, and a lifelong learning means that we need to not only maintain our core level of knowledge, but also maintain the fundamental technical and professional skills that we have, and expand those skills and expand that knowledge. Always hungry for learning something new, always learning what is the best way to care for a specific type of patient. And there's just not enough time in the educational guidelines dedicated to teach a paramedic everything they absolutely need to know before they step out on the streets. And so the education that we provide is level entry education, and we rely on you as a lifelong learner to expand your skills and expand your knowledge as part of your job. And it's important to note also, as a lifelong learner, that it does require us to have continuing education. That's why we have continuing education, so that we don't just stop when we come out of the classroom. If you look at the amount of continuing education hours that we have to have as paramedics, we have to have far more hours than physicians, than nurses, than most all professions in medicine. So we are required to continue our education in an effort to broaden and expand our skills and knowledge. Let's talk about professionalism in EMS. You know, we identified a profession as a group of similar jobs that serve the public, and it does require special knowledge and specialized skill sets. Well, as EMS providers, EMRs, EMTs, advanced EMTs, and paramedics, that is a group of similar jobs, and we do provide and serve the public, and we do have a specialized set of knowledge and skill sets. Not everybody could just walk off the street and do what it is we do. Now, professionalism is defined as following standards of conduct, performance for a given profession. So, as a professional, we are following a standard of care. And for us, those standard of care have been defined in our scope, they've been defined in our protocols, and they've been defined in programs like PHTLS and AMLS and ACLS and PALS. Now, ethics are expectations established by the community, the medical community, reflecting the views of conduct of that profession. So, you know, holding yourself, portraying yourself, living up to the expectations of a paramedic. Healthcare is just the provision of care to individuals. So a healthcare professional would be an individual with specialized skills and knowledge of medicine who provides care to the public. And that's exactly what we do. So we are healthcare professionals. And as a healthcare professional, the paramedic must maintain the highest standards of care and the highest standards of conduct. We must conform and uphold the standards of care. We must look, speak, act, dress, and like a professional, both on and off duty. We must maintain our knowledge and skills. We must provide the highest quality of care, do what is in the best interest for our patient at that point in time, not because we can, but because it is in the best interest of the patient. Treat our patients with respect and with empathy, trying to understand what it would be like to be in their shoes. Serve as a patient advocate, because oftentimes, particularly if our patient goes unconscious, we're the only way to communicate to other healthcare providers that take over care of the patient what the scene looked like, what the patient was complaining of, those sort of things. As a paramedic, we must earn the public's trust and respect, and we certainly do that by maintaining confidentiality and by conducting ourselves as a professional. If you look at most research, or if you look at most surveys that ask what is the most trusted profession in the United States, in most all those surveys, number one is paramedic. And that should instill pride in the work that we do. For most of us, it certainly isn't the money that keeps us in this profession, because there are other things in medicine that we could do that make more money. It's the pride in knowing that we make a difference. It's the satisfaction that you get when you're able to successfully diagnose a patient's life-threatening problem and provide care and save their life. Some other attributes of a paramedic include integrity, and that's doing the right thing, not doping, but doing the right thing, even if it's not popular or it's difficult to do. You know, there might be a way to take the low road or do something that's easier but not necessarily right. That's not integrity. We always have to make sure that what we're doing is in the best interest of the patient. It's the right thing to do, even if others on scene do not find it popular or it's very difficult to do. Empathy is demonstrating an understanding of the patient or the family and how they feel, understanding what it would be like to be in their shoes. Empathy requires us to demonstrate respect for others, regardless of the type of call. Empathy requires us to be calm, compassionate, and helpful, to be supportive and reassuring of others. As a paramedic, you need to be self-motivated. When we're out there on scene, there are times where we do have to make split-second life-saving decisions. And if we are wishy-washy, or certainly we're not confident in our abilities, we may not provide care that is necessary to save a life. So we have to be able to make decisions on a split second that can mean the difference between life or death and deal with the consequences later. Other attributes of a paramedic include to show respect. We certainly want to be respected, but we also have to show respect for others in medicine, understanding that there's a variety of ways to practice medicine, and because somebody doesn't do it exactly like we do doesn't mean that they're wrong. We have to keep a clean and neat appearance and keep clean and neat personal hygiene. Certainly if we're disheveled or our uniform or clothes are wrinkled, that doesn't put a lot of trust in the patient when we show up that way. As we mentioned, you have to have an air of self-confidence, not be cocky, not be a paragod, but do be very comfortable and confident in your abilities and of the skills that you can provide. We have to be able to communicate with others. We have to be able to speak clearly and confidently when dealing with our peers and perhaps physicians. We have to be able to write legibly, and I know that much of what we do is on computer, voice-activated software, those sort of things, but what we do on the computer still needs to be readable. It still needs to make sense. It still needs to have good sentence structure. We need to be able to listen actively to not only our patients but to others on scene that might give us clues as to what's going on. We have to be able to adjust our ability to communicate depending on any given situation, knowing that no two calls are going to be identical. And understand that certainly miscommunication or misinterpretation of what we say or do could lead to a serious mistake that could cost a life. We have these patients for such a short period of time. We have to be able to prioritize our time while caring for a patient or multiple patients. We have to be able to work with others as a team. We have to be very diplomatic, particularly if the care that's being provided upon our arrival is not appropriate or needs to be adjusted or changed. And certainly with others on scene that may want to take over, like physicians on scene or nurses on scene, we have to be very respectful and diplomatic in those situations. We are patient advocates. We are there to make sure that what is occurring is in the best interest of the patient, not because we can, not because we've always done it that way, but because it is what is in the best interest. We need to protect the patient's confidentiality, and we need to place the needs of the patient above our own self-interests. Careful delivery of service occurs when certainly we pay close attention to details and we master our skill set. Careful delivery of service requires us to be very familiar with our company policies, our company procedures, and the protocols. Understanding that not every patient is going to fit perfectly into a protocol, and that requires us, in addition to knowing our policies, procedures, and protocols, to be able to justify when we step outside those boundaries. Some other responsibilities, including primary responsibilities of a paramedic, include preparation for the day, preparation for the shift, safety prior to going on the ambulance call, making certain that everything's strapped down, that the vehicle is in good working order, that you have adequate supplies. And then responding to the scene certainly includes a safe and a safe response. Just because we can run with lights and sirens certainly doesn't mean we should go, balls to the walls and risk the safety of not only ourselves and crew, but the safety of the public. Scene assessment occurs when we arrive on scene, looking for a global overview for scene safety as well as any immediate life threats, and fix those life threats. Scene assessment and patient assessment allows us to develop a list of differentials that could be causing the patient shortness of breath or chest pain, and then through our patient assessment being able to rule out those differentials, coming up with perhaps one or two likely causes, and developing a working field diagnosis that directs and guides our emergency care, as well as make decisions concerning the proper destination, getting that critically injured trauma patient to a level 1, level 2 trauma care facility, getting that STEMI patient to a cath lab, getting that stroke patient to a stroke-capable hospital. Upon arrival at the hospital, being able to transfer the care over to nursing staff is an important responsibility. Documenting our patient contact and what occurred, and leaving that information with the receiving facility, because there may be times, particularly if the patient's unconscious, that the only record they have of what had happened is what you leave at the hospital. And then returning to service, which includes not only making sure that your supplies are restocked and your drugs are ready to go and you're full of fuel, but also a check on yourself, both your physical appearance as well as your mental thought at that particular point. Community involvement is an additional responsibility of a paramedic, not necessarily primary, but certainly we appreciate and understand as a paramedic the level of education on emergency medicine that we have allows us or affords us the ability to teach certainly emergency medical responders and EMTs and advanced EMTs. We also need to be involved in the community's efforts in prevention, illness prevention, recognizing the signs and symptoms of a heart attack or stroke, understanding the risk factors that lead to premature death, cardiovascular disease, injury prevention, participating in bike rodeos, child safety seats, programs in the schools that address slowing down, wearing your seatbelts, don't drink and drive. Those sort of things are important, as we are the eyes and the ears of the injury prevention initiatives. We know whether they're working, and we should be actively involved in helping prevent these things from occurring in the first place. That whole working with the community, that's supporting their primary care efforts, encouraging citizens to understand what we do as EMS. We're not ambulance drivers. We have a variety of specialized skills, and that we've come a long way in the field of EMS. And we will continue to develop our personal and professional skills as we grow in the profession. Now, a medical director in Iowa is a physician or a physician advisor or a physician extension, and the medical director or physician advisor should be actively involved in your EMS system development, your training and education, your protocol development, and should be perhaps the person that picks the radio up if you're calling in for orders, or you're calling in just to get some guidance or information on a particular patient. Your medical director and physician advisor, as I had mentioned, actively works in development of your protocols. Now, we have a group of physicians and paramedics and EMS providers that write the state protocols, and many services use those as their base and then change or incorporate their own way of doing things, which is okay, but we just don't want to dilute the wide variety of ways that healthcare can be provided, so that we're back in a situation where it varies so much from county to county. We'd like to try to make medicine in Iowa more in line with each other. So your medical director should work with developing protocols, should work with developing standing orders, and provide online medical direction, as well as offline medical direction, which could be prospective. In other words, prior to providing care, that'd be education, training, protocol development, and then retrospective, after the call is over, run audits and chart reviews. Which leads us to quality improvement, quality assurance, and continuous quality improvement. And these are all things that are very similar in nature. Certainly quality improvement is improving upon the care that we provide, looking at opportunities that exist based on run audits to provide better care. And that's what quality improvement and quality assurance are, retrospective medical review. It should not be punitive. Quality assurance should not be punishable. It should not be a reason to kick somebody off or fire somebody. Certainly they should be opportunities to make changes, and then it would be up to the individual to educate and train themselves so that they didn't, create that same opportunity. Continuous quality improvement is the ability to look at benchmarks and hold yourself up against others in your profession, or hold your service up against other benchmarks. And we're developing benchmarks on a national level through evidence-based practice, as well as through NEMSIS, which is another National Emergency Medicine Information System, where multiple states from across the United States all dump their run reports and into this cube, into this database, so others can pull, sort, query what the average on-scene time is, how often is this particular drug being given, and those things help develop continuous quality improvement as well. EMS research. There is some research going on in EMS, not as much as certainly I'd like to see. But the problem with EMS research is that it requires a special subset of education to conduct it. It costs money, and there certainly is little money in research and very little money in EMS research. Often what we do in EMS, we just take from what has occurred inside the hospital and extrapolate that to EMS. EMS validates our existing treatments and protocols. EMS allows us to provide evidence-based medicine, which we believe equals better patient care, and EMS research helps us improve our systems. You've heard of garbage in, garbage out, and certainly data, if the data is garbage going in, when we pull it out to analyze it on the back end, we certainly aren't going to get very good information. So the data comes from your run reports. So it's very important that your run reports reflect what actually occurred and provides good data. When we look at EMS research, it may begin with a literature review, and a literature review is a literature search for a particular topic, and you want to make sure that it's peer-reviewed, that it's been reviewed by your peers or services of your level or higher. You want to look at the table of contents and make sure that it addresses the same things that you're trying to look at so that you can draw a similar conclusion, comparing apples to apples. And then determine the strength of the study. And the strength of the study is dependent mostly in part by its design. Was it a prospective study? Was it a study where everybody was educated on what needs to be done and then measure those outcomes? Or was it a retrospective study? Retrospective studies include things like, let's train everybody to the 2010 AHA guidelines on how to perform high-quality basic life support. And then here we are 4 years later. Let's look back over the last couple years and see whether or not services are providing high-quality basic life support as defined by the guidelines. That's retrospective, and that's probably the most common type of research that occurs in EMS is retrospective review of audits and run reports. A cohort study is, again, those involve understanding, what the outcomes need to be and working to achieve those. Study designs can be case controlled, where you really narrow it down to a particular type of case, and that's all you're looking at. They can be randomized, and a randomized controlled study is perhaps the strongest type of research, particularly when you're involving humans. And a randomized controlled study is sort of difficult to do in the United States. It's not impossible, and we do some, but a randomized controlled study would be I have this drug that really helps people breathe better, but I want to know how well it works. So on even days, those people who can't breathe get the drug. On odd days, those people who can't breathe get water. Well, if the drug actually does work and make a difference, all those people on the odd days that didn't get a drug, that just ethically wasn't the right thing to do. So it's hard for us to do randomized controlled studies, but when we do, they certainly are very strong, particularly if they involve humans. Studies can be blinded, single-blinded, where one part of the study group knows what the what's being measured, and double-blinded, nobody in the study group knows what's being measured. And that would be like a double-blinded study would be, when they were studying the difference between lidocaine and amiodarone. In a double-blind study, EMS providers were given a drug called drug X, and they did not know whether that drug was lidocaine or amiodarone. The study, the people who developed the study knew what drug X was or what drug Y was, but the people who gave it had no idea. And so that kind of takes out maybe perhaps a personal bias of how a person might feel about lidocaine or amiodarone. In evaluating research, we also have to look at the class of evidence. Class 1 evidence is the best. Class 3 is not quite as good. Class 1 is your randomized controlled trials, large human populations. Class 3 evidence, maybe some human populations, some strong data, some strong evidence involving animals, retrospective studies, those sort of things are Class 3 evidence. We also have to look at the patient population because, certainly much of what we get out of combat comes from young, healthy, injured soldiers. Well, can we take that same information and apply it to the geriatric population with multiple medical problems and on multiple different meds and expect the same sort of results? Looking at how the data was analyzed and the results of that analyzation are important as well. And then your role in EMS in research is to make certain that your ambulance run reports are an accurate reflection of what happened, that they're filed timely, because as we do research, most of that, if you're not actively participating or asked to participate in a study, most of what we will pull is going to be retrospective based on what you put on a run report. So in summary, EMS is a dynamic field. It's young, it's got a proud history, a very exciting future. This is really an exciting time to be in EMS as FICMs and other federal agencies as well as state agencies all come together working off the same design template in developing evidence-based practice. And EMS systems are an integral part of the medical community. We are an extension of the hospital. The education that you receive in this program is the beginning of your education. It certainly doesn't end when the year's up. You need to be a committed lifelong learner. You must be licensed or certified to practice your paramedicine under the auspice of a medical director in the state of Iowa. And if your credentials expire, you're unable to practice. And so we have continuing education requirements, CPR requirements, things that the state believes we should be able to accomplish every 2 years in order to remain credentialed. National, state, and local EMS organizations work to build EMS, and you should participate, whenever possible. People often ask me, what can I do? Well, start at the local level. Certainly look at the regional level, then on to the state and national. That's what I've been successful in doing. I serve on several national committees. I've done some international education. I've been very fortunate to work with some very brilliant, gifted people in writing books and developing programs. And it's because when asked, I participated. So if you get those opportunities, participate, seek them out. Let people know you're certainly welcome or that you're willing to volunteer, because most all of what this does is on a volunteer basis. And remember that professionalism is a daily commitment both on and off duty, that your medical director functions as your medical conscience, and should be consulted with all aspects of your system development and growth, and that research is critical if EMS is to grow and expand. Well, I thank you this evening for listening to this very first of many lectures, and should you have any questions, feel free to contact me at that web address there. That's my work email. Feel free to call me at 712-320-8220, or feel free to leave me a message on the message board on the Iowa Western Community College Paramedic webpage. Thank you, and I'll talk to you soon.